We are doing this weekly case meets. Everybody knows now. And today's topic is cleft lip and palate surgery, challenges and solutions. And our speaker, today's speaker, Dr. Vibhawari Naik ma'am. She is a senior consultant, onco-anesthesiologist and intensivist. Presently, ma'am at Baswatarakam Indo-American Cancer Hospital and Research Institute, Hyderabad. Madam's area of interest are pediatric anesthesia, onco-anesthesia, vascular assays, and academic. Other achievements are speaker at various national and international forums, more than 45 plus publications, plus 6 book chapters written by ma'am. IAPA Pediatric Anesthesia Fellowship Award was given. Associated with Smile Train Cleft Charity, more than 18 years, and national training faculty with them. Madam was past treasurer, Indian Association of Pediatric Anesthesiologists, even executive committee member of Asian Society of Pediatric Anesthesiologists, runs ICA and SOAPC accredited onco-anesthesia fellowship programs and DNB palliative care medicine at Baswatarakam, and presently editor at ISA Hyderabad. So, ma'am, very much welcome on this evening. Screen is yours now.
Sure. Thank you. A very good evening to everybody. Thank you, Dr. Sachin, Dr. Kotkar, and the entire ISA Nanded team for inviting me here today to talk on a topic that's very close to my heart, and that is cleft lip and palate surgery, anesthesia for these children. I bring greetings from Basavatarakam Indo-American Cancer Hospital and Research Institute, Hyderabad. Is my slide moving, Dr. Sachin?
Yes, ma'am.
Yeah, right. I always find being an anesthetist for a plastic surgeon is the most challenging job because the area that they work is extremely diverse. And particularly if you're anesthetizing a small child with a cleft, it is even more challenging. And today we are going to discuss some of the challenges and some of the solutions that I have kind of encountered, and I will be sharing it with all of you. I wish to mention Smile Train, which is a global cleft charity organization. Smile Train India alone runs more than 150 centers across India and has sponsored more than 1.2 million surgeries. It's my privilege to be attached with them for more than 18 years now. Our Smile Train Center is a tertiary level Smile Train Center, which allows complicated cases to be operated. And I've also been involved in training teams in cleft care and have been conducting workshops for Smile Train. I have also volunteered to work for Lifeline Express, which is the hospital on train, and anesthetized a few cleft cases there, where I could get experience of working in lesser resourced situations. So I hope my combination of working in an institute, a tertiary care center, as well as working at low resource center will help put some thoughts across, which hopefully should be helpful for a few of you at least. Now, let's begin with a hypothetical case. This 9-month-old baby with cleft lip and palate coming for repair. How do we proceed? Before I really go into the nitty-gritties of managing this patient, let me just put forth the magnitude of the problem. In India, a child for every 800 live births is born with clefts. And these clefts can be different types. I'm not going to go into the classification, but it can be either a cleft lip or a cleft palate or a combined cleft lip and palate. And it can be unilateral or it can be bilateral. A bilateral cleft lip and palate together can have this sort of facies where there is a premaxilla which juts out, and this can further increase the difficulty in managing these children. Also, there could be clefts associated with other facial anomalies, and particularly this patient with bilateral facial cleft. Now, what is the right time to operate? I'm sure rule of 10 has been described in books and is a very typical question to be asked for postgraduates. But for practical purposes, cleft lip can be operated as early as after birth within the first week, though most of the plastic surgeons in our country would operate cleft lip at 3 months. And this is because the Indian Society of Cleft Lip, Palate and Craniofacial Anomalies provides guidelines where it says that it is safest to operate 3 months and beyond the cleft lip. In our institute, because we are a Smile Train center, Smile Train wants us to operate a child only when the child is 5 kgs and beyond. Cleft palate is operated at a little older age, probably 8 to 9 months. My hospital, we prefer to do a total correction, that is operating the lip and the palate in the same sitting, and we would usually do it beyond 9 or 10 months and make sure that the child is at least 8 kgs. Now, these children have to undergo multiple procedures after their primary repair, and that could be palatoplasties, VPI corrections, cleft lip and nose deformities, alveolar bone grafts, and so on. And hence, it's important that we as anesthesiologists play an important role in the journey of this child and their parent so that this journey is much more smoother for them. Now, coming back to the topic, what are the challenges in preoperative evaluation of these children? I think the most important point that here we need to identify is if this child is having an active upper respiratory tract infection. Now, the problematic area here is that chronic rhinorrhea is very common in these children, and frequent nasal regurgitation is going to cause frequent upper respiratory tract infections in these children. But in younger children, since this is an airway surgery, we have to be all the more sure that this is just a benign nasal discharge and not an upper respiratory tract infection. So how do we identify it? If the secretions look purulent, if in the last 5 days there's history of fever, cough, if the counts are raised, and if there are lower respiratory tract signs, then you have to avoid operating this child. You need to correlate it with labs, and I'm going to come to it a bit later. You have to start antibiotics if you're suspecting it to be bacterial. If it's viral, you can just wait it over for 2 weeks and get the child back again for surgery. Now, airway evaluation is yet another very important aspect, and identifying a difficult airway in a pediatric patient is challenging. So let me just go through what are the pointers that could tell us that this airway is going to be difficult. In the history, if there's difficulty of breathing at birth, if there have been obstructive sounds during sleep, if the child was nursed in prone position or is still being nursed in prone position, these are the pointers that this could be a difficult airway. And of course, facial features. Facial features of various syndromes, like there could be frontal bossing, there could be hypertelorism, that is the both eyes are farther away, as in this child. Here there is gross facial asymmetry, and sometimes the facial features are extremely subtle, like in this child where there is just a mild retrognathia, but the child does have large tongue and does get nursed in prone position. So it's very important. It's not just the looks, but it is based on the history that you take from the parents that will help you identify a child with a difficult airway. Malampatti scoring definitely is not useful in very young children. So what should be followed? There is a score that has been devised to identify difficult children, particularly the syndromic children, to identify the difficult airway, and that is called as the COPUR score. And COPUR stands for Colorado Pediatric Airway Score. It has got 5 components by looking at the chin, by assessing how much the mouth can open, if there is a previous history of difficult intubation or a history of snoring, as I just mentioned, how much part of the soft palate or uvula is visible, and the range of neck movement. There are some additional points that have been given if the tongue is large size, if the child is obese, or there is associated mucopolysaccharidosis. A score more than 8 would qualify for difficult airway. There are specific features in cleft children that could make the airway difficult. And these are, if the child has isolated cleft palate, because isolated cleft palate is commonly associated with a syndromic child. If the cleft palate is wide, if the child is younger than 6 months, if the weight of the child is less than 6 kgs, and if there is bilateral cleft with premaxilla, and of the various syndromes, if there is retrognathia or if there is short neck. So various studies, retrospective studies have shown that if there are these parameters, one could anticipate difficulty in airway management. This was an interesting child that we had. As you can see, the tongue is extremely large, but you can actually look at the epiglottis that is jutting out there. So almost like a Malampatti grade 0. And though it was difficult, there was some difficulty in mask ventilation, the intubation was extremely easy for this child. Coming to various syndromes, I think it's impossible to really memorize all the types of syndromes that can be associated with cleft patients. There are more than 200 syndromes that have bone documented. But I think important points to highlight here are, if there is a child who has associated skull bone anomalies, which means there is some form of craniosynostosis, you have to take history for seizures, and you have to rule out if there is raised intracranial pressure. If there is a child with widely set eyes, that is hypertelorism, remember that this is going to be associated with maxillary hypoplasia, and this is going to cause difficulty both in mask ventilation as well as intubation. A grossly dysmorphic facies, like here you see that the left and the right side of the face is difficult, and these are probably the most high-risk patients because this can be present in Crouzon's syndrome, where the airway is difficult and ends up being more difficult as the child grows. Retrognathia, as I had mentioned earlier, is another important pointer. In this girl, the retrognathia is very, very overt, but as I showed this picture of this baby earlier, sometimes the retrognathia can be very subtle and has to be confirmed on history. Now, 2 important syndromes that you need to be aware: Pair-Robin sequence and the Treacher-Collins syndrome. Pair-Robin sequence is mainly related to retrognathia and a large tongue. 80% of these patients would have cleft palate. But the best part about this sequence is that the airway keeps improving with age. So for an identified Pair-Robin sequence, we often do not operate these children at 9 or 10 months of age. We wait till the obstructive symptoms subside, and it can sometimes be a little over a year or maybe 15 months that these children would be appropriate to be operated. Whereas Treacher-Collins syndrome is associated with maxillary hypoplasia along with mandibular hypoplasia. So there is going to be retrognathia as well as other dysmorphic features that you can see in this picture. But the issue with this syndrome is that airway does not improve with age. So if you have, say, successfully intubated this child in the first sitting and the child is coming again for a second sitting for some other repair, then it does not guarantee that it is going to be an easy intubation. You have to remember that the airway can in fact worsen in Treacher-Collins syndrome and Crouzon's syndrome. another important component, and that is called as physiologically difficult airway. So till now, I have just spoken about the anatomical factors that could increase the difficulty of the airway. A child who has history of snoring, history of frequent upper respiratory tract infection, history of passive smoking, maybe the father smokes in the family, has evidence of eosinophilia, or has presence of congenital heart disease. This child is at an increased risk of desaturation and hemodynamic instability, making it a physiologically difficult airway. So all these pointers also need to be identified and taken into consideration. Now, what investigations should be asked for? These are the routine investigations that we do for all our patients. That is the complete blood count. We do a PT-INR, we do a blood grouping, and we do viral markers. Now, based on the requirement of the patient, further investigations are done. If the PT-INR, if the INR is more than 1.3, we put the child on vitamin K supplementation and call the child back again when the INR is at least 1.3 or less. In the complete blood count, I want to bring your attention to the variations of the WBC count that can normally occur in a healthy child. And the counts are usually higher when the child is younger. So at 1 week, the total WBC count of 21,000 is considered normal. And slowly, the upper limit of the WBC count starts dropping as the child starts growing up. And even up to 1 year, a total WBC count of 17,500 should be considered normal. Parallelly, you would notice that the neutrophil percentages are much lesser in children as compared to adults. In adults, a neutrophil percentage of 60 to 70% is considered normal, whereas in children, 30 to 40% is considered normal, and the neutrophil percentage starts increasing in children as they grow older, and probably beyond 10 years, it would be closer to the adult values. Now, coming to eosinophilia, I think it's very important that you look at the absolute eosinophil count whenever you're looking at the total WBC count. And this is because the eosinophil count is raised in certain situations like allergic bronchitis, children who have asthma, children who have cutaneous allergies, worm infestations, and filariasis. Now, this study showed that if the eosinophil count is raised, these children are associated with higher perioperative respiratory complications. And this is why the eosinophil count is relevant for us. Now, this study actually looked at what percentage of patients who are coming for cleft lip and palate repair have eosinophilia. And if you look at this, almost 1/3 of the patients who come to us for cleft surgeries can have eosinophilia. In our hospital, we take the absolute eosinophil count of 1,500 as the cutoff. And if the absolute eosinophil count is more than 1,500, then depending on the cause of the eosinophilia, we would treat the child. If there's worm infestation, you can give a single dose albendazole. For filariasis, diethyl carbamazine is given, and allergic bronchitis, you may want to start them on bronchodilators. What about routine chest X-ray? Is it required? No. Routine chest X-ray is not required, but you should get it done if it is a child with congenital anomalies. What about 2D echo? Is it required for all children? Again, no, we do not do it for all children, but a good clinical examination will help you identify which child could require a 2D echo. So if in history there are episodes of cyanosis, failure to thrive, the child gets tired soon, or keeps stopping while the child is drinking milk in very young children, If there is presence of either pansystolic or a diastolic murmur, if the murmur is a little louder and has systolic click, then there is a possibility that there could be associated cardiac anomalies and you need to get a 2D echo on this child. The prevalence of congenital heart disease in non-syndromic cleft lip and palate, as per the systematic review, is about 7%, and different studies would put it at a range of 7 to 15%. But if you look here, it's the highest in children with isolated cleft palate, which means if you have a child with an isolated cleft palate, it is important not just that you rule out other congenital anomalies, but also try and rule out congenital heart disease in these children. Now, what is the anesthetic technique that you're going to use? Now, here, let me confess that there are many ways to manage these children safely perioperatively, and it entirely depends on what you are comfortable in doing, what your team is geared to handle, what kind of setup you're working in, and what are your backups. I'm sure there are many who are listening here and have their own styles of anesthetizing their children. I would really like to hear them out and talk about it in the Q&A session in the end. But what I thought I'll take you through is what we follow. Pre-medication. Is pre-medication really required for all children? Maybe not. If a child is less than 6 months, you really do not need to pre-medicate the child. Just keep the child warm and cuddle the child, and you can kind of get the child inside the theater. If the child has, if you're anticipating difficult airway or the child has some obstructive symptoms, again, be extremely careful while you pre-medicate this child. Children between the age group of say 6 to 9 months to up to 3 years are possibly the most difficult to kind of take inside. And this is the age group where we actually pre-medicate. And the most commonly used pre-medication by us is triclofos or the chloral hydrate syrup. The syrup is sweet, well tolerated, and we give it in a dose of 100 milligrams per kg. It takes about half an hour to 40 minutes to act. If you're looking for a little faster induction, midazolam syrup or dexmedetomidine, either oral or intranasal, can be given. Midazolam is not available now, and I haven't been using it for some time. But dexmedetomidine, especially intranasally, really works quickly, maybe in 15-20 minutes, if you think that the child is still not sedated. And for a very combative child who's just thrashing around, maybe IM ketamine can be used, but it's been a while that I have used IM ketamine now. I think the best way is to get the children involved in whatever they like to do. Like if you look at this picture, mobile phones, they are their best buddies. They can even leave their parents if they have their favorite YouTube video going on their mobile phone. So that's what we like to do in our hospital. We kind of show them their favorite YouTube videos. We get into a conversation. We see if we can put an IV line for a child that is a little older. If the child is between the age group that I said, between 6 to 9 months to 3 years, we prefer to take them inside and do an inhalational induction and put an IV line. So again, as I do an inhalational induction for this child, I'm showing their favorite video to them so that they can keep watching the video as they breathe in through the mask, sevoflurane going on, and you can see how slowly as they watch their video, they kind of fall off to sleep, and then we are ready to put an IV line on these children. A word of caution, make sure that these children are not over fasted, because if you're going to put an IV line under inhalational induction and the child has been fasting for long hours, the veins are going to be collapsed. The veins are going to be collapsed. You are given full dose of sevoflurane. Again, the veins are going to be collapsed. So it's going to be a little difficult. So make sure you adhere to the fasting guidelines. You give the child clear oral liquids about 2 to 3 hours before you take the child inside, maybe a Glucon-D solution or something, so that the veins are filled well. Another way of doing things for little older children is to use the Prilox cream, and you can put the Prilox cream, and as I showed earlier, you can show them their favorite YouTube video while you cannulate this child. If the venous access is difficult, some of the gadgets that are available are the infrared it's called as the view. I think I just forgot. I forgot the name, but this is what is a vein view. The vein view is available, which uses infrared technology, or you can use trans illumination to highlight the veins. So this is how you would put an IV axis for a very young child. Look at the way I'm holding the hand. So the first finger is actually trying to create pressure, while the remaining fingers, especially the thumb, is stretching the skin to make the skin taut. This is the way you squeeze the hand so that the vein becomes prominent. And I like to take a nick so that the cannula goes in smoothly. And once you puncture the vein, you would see a backflow there. And then you have to make sure you thread it in properly. So this is one of the techniques that the vein can be cannulated in very small children. Sometimes the veins can be difficult, a little older children, because of multiple surgeries that they undergo. And we fortunately have an ultrasound which we use. We use the linear probe, the hockey stick probe, and here you can see the cannula that is coming inside the vein. The moment you see the white dot coming in the vein, you're going to get a back flow there. Confirm that the backflow is good, and then you can thread the cannula inside. Now, coming back to the most important and the most challenging part in these children, and that is airway management. The most common method of securing the airway in these children is using the South Pole or the RAE tube. But as you can see in this child, depending on the discrepancy between the child age and the weight, sometimes the child is older, but the weight of the child is small. In such situations, there's a possibility that the RAE tube does not fit well. Like the curve, the black line, which needs to be there at the lip, is seen jutting out. So either you can cut the extra length of the tube and put a roller gauze, or after you position, you can put in some extra padding there so that the tube is stabilized. Micro cuff tubes are available, and the advantage with them is that the cuff position lies more distally, so it stays away from the point of the narrowest part of the pediatric airway, that is the subcricoid area. There are other ways to secure the airway in these children, and some centers, I know my friends are using the flexometallic tube in these children, but I have no experience with these tubes. We have occasionally used a supraglottic airway. You can see the igel sitting there, and these are typically used for incomplete cleft lips where the alveolar margin is not going to be touched. So supraglottic airway can be safely used in this group, but definitely the surgeon is going to find it difficult because it's just sitting in the way. So a flexometallic LMA can be better adapted to these situations. Now, selecting the correct tube size. Particularly if you have a child where there is a significant discrepancy between the age of the child and the weight, like in this child with tetraphocomelia, it's very difficult to anticipate what is the appropriate tube size. And in such situations, the most helpful way is to use the ultrasound machine, put it in front of the neck, and try and look at the transverse diameter in the subglottic area, and that is going to give you an idea which is more accurate than the age-based formula. For intubating, you can either use the routine Macintosh blade or you can use the Miller's blade. Now, Miller's blade is extremely useful when the space in the oral cavity is less. So when the mouth opening is less, when there is retrognathia, Miller's blade is much more useful in intubating these children. Also, the fact that the typical Macintosh blade in a child with left-sided cleft can keep slipping into the cleft and making the space narrower and increasing the difficulty of intubation. Special blades that are available, like this, Dr. Dhulkade had devised a wider flange for this blade, but I have no experience in using this. What we prefer doing in our setup is to just tuck in a rolled gauze in the cleft so that it provides support as well as minimizes the trauma to the mucosa there. There are many video laryngoscopes, and I'm sure a few of you already have and are using video laryngoscopes. It is important that if you're managing children, you also look for video laryngoscopes that have pediatric blades, and video assisted intubations really improves the safety and efficacy in intubating these groups. If you're using a blade that is hyperangulated, remember that even though you're using an RAE tube which is curved, it may sometimes not reach very anteriorly, and you may require either a stillet or a bougie to be put in the tube so that it is bent anteriorly. And this is a video that I have to show you. This is actually the adult blade that I have used here for CMAC, and you see that the RAE tube is just going posterior. The view is very good for me, but I'm unable to intubate. So I've used a bougie, and now over the bougie, we are trying to railroad the endotracheal tube, and this is how we have intubated it. So remember that whenever you're using a blade that is discrepant of the size, or if it is hyperangulated blade, it is always better to use a bougie or a stillet to bend the tube anteriorly. This is another video that I have for you, and you can see this child who had subtle retrognathia. We are using a pediatric video laryngoscope blade, but even after manipulation, the best view that we could get is just the posterior aspect of the larynx. And fortunately enough for us, just with that limited view, we were able to intubate this child. Moving on to a very important topic that has been in discussion of late, and that is regarding throat pack. To be or not to be? Would you want to put a throat pack, or would you not want to put a throat pack? Well, traditional teaching, we've always used throat packs, but recent studies have shown the harms of using throat pack because of increasing because of the throat pack, there can be mucosal injury, there can be swallowing difficulties, there can be more of injury to the mucosa in the pharyngeal area. And this systematic review looks at the benefits and harms of routine anesthesiologist inserted throat packs in adults. And the practice recommendation says that routine placement of throat pack by the anesthesiologist should be avoided. But it can be placed by a surgeon in a way that is suitable for the surgery, and making sure that it is not tightly packed, because all the harms of using a routine throat pack is because of the way we are trained to put the throat pack. We are trained to kind of tightly pack the throat pack around the tube so that the tube doesn't slip out, or just to make sure that whatever bleeding is occurring does not enter the larynx. But this is probably not the most appropriate way of using a throat pack if you're going to use. Also, it is important to remember that we have to mark it or label it somewhere that we have put a throat pack, so that we remember to remove it. This specific study actually looked at in children undergoing cleft lip and palate surgeries, and they had two types of surgeons, one who liked to put the throat pack and the other surgeon who did not like to put throat pack. And they tried to compare the results, and their conclusion was that it is okay to omit the throat pack in cleft lip and palate surgery. Cleft palate surgery, particularly because of the position, whatever bleeding occurs is going to fall in the posterior pharynx and will not be directly close to the airway, as long as you have made sure that you have performed a good suction before this position is removed to normal position. Now, you've intubated this child and the surgeon has started. The first thing that they do is that they put in a Dingman retractor and they open it up. It is very important for you to be vigilant at this time point, because as you can see here, the tube is getting kinked and bent because of this retractor, even though this tongue blade has a slot for the endotracheal tube. So you have to keep an eye on the airway pressure and visually inspect while the surgeon is opening the mouth gag. One of the ways that we found useful is that we use this needle cap as a spacer between the tongue blade and the lower alveolus, so that it just lifts the tongue blade a little away from the tube so that it reduces the pressure, direct pressure on the tube. Now is the time for the surgeon to infiltrate adrenaline. How much adrenaline would you allow your surgeon to infiltrate? There has been incidences where inadvertent intravascular injection of adrenaline or a high dose of adrenaline infiltration has led to supraventricular tachycardias or acute heart failure in these children. So you have to be vigilant. You have to calculate the amount of adrenaline that you can allow your surgeon. The dilution, you have to make sure that they make 1 in 2 lakh dilution, that is in 200 ml of normal saline in a bowl. They can add 1 ampule of adrenaline, and depending on the volatile agent that you are using, you can allow a maximum dose of say up to 4.5 micrograms per kg with isoflurane or 10 microgram per kg with sevoflurane. If you're using halothane, then the maximum dose of adrenaline is much lower, and that is 1.5 microgram per kg. Such a tachycardia, if it occurs, it's usually self-resolving. Put 100% oxygen and keep monitoring the patient. You can give a small dose of fentanyl to increase the depth, a little bit of propofol that will help you get the heart rate and the blood pressure down. If it still does not resolve, then any beta blocker, either an esmolol or a small dose of metoprolol can be given to get the heart rate and the blood pressure down. Now, as you plan, you have to take into consideration the perioperative analgesia for these children. So what are the options that are available? If cleft lip is being operated, infraorbital block can be given, and there are 2 ways of doing it. Either it can be given transmucosal. So this is the surgeon, after finishing the palate surgery, is giving an infraorbital block. You can see the left hand is trying to feel the inferior orbital margin and the inferior orbital foramen, making sure that the tip of the needle is not going beyond this point, and then infiltrating 1 ml of the local anesthetic. Whereas another way of doing it is in probably a little older patients is to give it externally, where you can actually feel the dip in the inferior orbital margin and then mark it and give the local anesthetic there. There is very good quality evidence that infraorbital block is very useful in reducing the postoperative pain in these children. Some surgeons prefer using local anesthetic infiltration. So they can either use 1% lignocaine with adrenaline, so both the adrenaline infiltration as well as local anesthetic is covered up, or if they are wanting to give the adrenaline infiltration separately, then bupivacaine or ropivacaine can be used in the toxic limits. Palatal nerve block has also been described. The palate is supplied by 3 important pairs of nerves: the greater palatine nerve, the lesser palatine nerve, and the nasopalatine nerve. And this is how you would block the greater palatine nerve, where it exits in front of the first premolar, the lesser palatine nerve just behind the greater palatine nerve, and the nasopalatine nerve near the incisive foramen. Recently, there has been increased interest in giving maxillary nerve block in these children. So basically, maxillary nerve, as it exits the Gazerian ganglion, supplies both the lip as well as palate. The branches of maxillary nerve will supply both. So a suprazygomatic approach to blocking maxillary nerve in these children is preferred, and this is how it is done. So the first step is to identify the frontozygomatic process. So you have to feel a dip, which is between the frontal process and the zygomatic process that runs horizontally. And after you've identified these two processes, you try and go closer to the angle made between them, and you go vertically first, go down till you feel loss of resistance, then come out just a millimeter and direct it towards the ipsilateral nasolabial fold. Aspirate well, making sure that there is no blood coming, because maxillary artery is in very close proximity in this location, and you have to make sure that you haven't injured any vessel. So 0.15 ml per kg of bupivacaine or ropivacaine can be given bilaterally. And if you want, you can add a small adjuvant like dexmedetomidine in the dose of 0.5 microgram per kg to improve the duration of analgesia. So now finally, you're going to ask me, you told us so many different types of blocks, and what should be done? What do you want to do? So I think the solution is with the team. It depends on what your surgeon is comfortable and what you are comfortable in doing. But if you want to look at the literature that compares bilateral suprazygomatic maxillary nerve blocks with both infraorbital and palatine nerve blocks says that bilateral suprazygomatic maxillary nerve block is an effective and safe alternative to the peripheral nerve blocks for cleft lip and palate surgeries. So, but it is not superior. It is effective and quite equivalent. So it is entirely up to you and your comfort in selecting the nerve block. But whatever you select, it is important that you select a nerve block, because that is going to help in a good post-operative analgesia for these children. I definitely wanted to mention about the IV fluids. I'm sure most of you are not using Isolite P, but if there is anyone who's using Isolite P, I think it is important to stop using Isolite P in smaller children. For younger children, you can make 1% DRL, that is made by adding 20 mils of 25% dextrose to 480 ml of RL bottle, and older children can receive only rivalactate. It is always safer to use a burette set so that you can add whatever is the required quantity, or use a dosiflow rather than using a regular intravenous infusion set. Okay, so we are at the end of the surgery. Everything has sailed smooth so far. Now, what are the important points that you need to check before you want to start extubating these children? So a pre-extubating checklist that I like to follow. The first and the most important thing is to make sure that if you have kind of kept the child a little deep, make sure that you start getting the child a little lighter, normalize the blood pressure so that the surgeon is able to identify bleeders, because in palate repairs, there are raw areas that are left. So once the surgeon has made sure that the blood pressure is close to normal and there are not any bleeders, it is more safer to proceed for extubation. Nasopharyngeal suction that I had mentioned, that before you take the child out from that position, a good nasopharyngeal suction is going to be of use. And this is how we do it. We use a metal Yankau's cannula in the oral cavity, and through both the nostrils, we use normal saline that is flushed and aspirated from the Yankau's cannula. So this is the way a good nasopharyngeal suction can be done. The next step is, if you've put a throat pack, or if the surgeon has put the throat pack removal. If the throat pack is being removed, let it be removed while the gag is still in place and partly it is relaxed, so that the gag blade is actually going to provide a support for the endotracheal tube. Otherwise, if somebody just quickly pulls the throat pack, there is a possibility that the tube can slip out. So this is a useful way of removing a throat pack. Also, while the retractor is being removed, look at the way the forceps is used to hold the endotracheal tube while the retractor is coming out. Again, this is a way to stabilize the endotracheal tube so that the tube does not get displaced when this retractor is being removed. And then making sure that there is adequate reversal of the neuromuscular blockade, and either extubating the child in a lateral position, especially if the child is small, is very helpful. If you are anticipating post-operative airway obstruction, the two useful techniques are, first is using a nasopharyngeal airway, and a simple uncuffed endotracheal tube is can be used as a nasopharyngeal airway. The tube size can be similar or maybe just one size smaller. Once you put it under vision, where the tip, do not put it blindly, put it under vision before your gag is removed so that you can see where the tip is exactly lying, and then you can actually cut this endotracheal tube and get the connector put back in again. The another useful maneuver is to do a tongue stitch. But the tongue stitch that we like to do is a deeper tongue stitch. So you see that the tongue is actually pulled out. This child had a very big tongue, and a deeper tongue stitch is taken on the posterior aspect of the tongue, because that is the part that is actually going to fall in the pharynx and obstruct the airway. So a deeper tongue stitch is much more useful than a superficial tongue stitch. But please remember that tongue stitch and nasopharyngeal airway are not required in all the cases because they have their own problems. Nasopharyngeal airway can get blocked because of the secretions, and you may have to keep putting saline drops so that the secretions don't thicken and crust inside. And the tongue stitch should be used only when necessary. For rest of the time, even if you put a tongue stitch, the tongue stitch has to be relaxed and put, because it's going to interfere with swallowing for this child. And tongue stitch, a deeper tongue stitch can also come with problems. So of the many tongue stitch that we've done for many years, I remember this child very conspicuously who actually swallowed the deeper part of the tongue stitch. So the deeper part of the tongue stitch was just not available for us to remove in the post-op period. And we again had to take him to the OR, gas him down with an inhalational agent, and then remove the thread. So just remember that each of the technique can be associated with problems, and hence you have to use them judiciously. Now, coming to the post-operative care, I think the most challenging part in these cases is to have a calm and an arousable child. So child should not be crying, because if the child cries, there'll be more bleeding. And if the child is deeply sedated, there is a chance that the child will obstruct or can aspirate if the child starts bleeding. So some of the techniques that we like to follow are the way we nurse these children. So if the child has undergone only palate repair, that is, there is no lip repair done, and probably these are the patients who would are more prone for respiratory obstruction, we like to put them in prone position like this, so that the tongue falls forward, and if there is any bleeding, again it will be collected on this gauze piece that we can see. But if lip is operated, then this is not the best position, because the lip wound can get injured if the child moves the head. And in that situation, probably these two are more comfortable positions, putting the child lateral on the mother's lap, or the mother can hold it on her shoulder in such a way that the head is tilted down and the secretions are coming outside. Okay. So what are the causes of post-operative respiratory obstruction? The most important cause is that palate gets lengthened, or If the surgeon has done either a pharyngeal flap or a tongue flap, these are the reasons why these children can have postoperative respiratory obstruction. Another reason could be hematoma. So if you look at this child, there's a big hematoma sitting in the palate, and that is causing all this swelling and is causing difficulty in breathing for this child. This child needs to be taken up for surgery again. Also, there can be edema. Edema can be laryngeal edema or there can be tongue edema. There are reports of tongue edema because of long duration of gag placement. And one needs to remind the surgeon to loosen the gag if the gag has been placed for more than 90 minutes so that the blood flow to the tongue improves and it will not end up with tongue edema. The best drug, the wonder drug for these children is dexamethasone. Dexamethasone should be used as prophylaxis for all children undergoing cleft lip and palate surgeries. We prefer to use only a single dose, that is 0.15 milligram per kg at the beginning of surgery. It not just helps in providing multimodal analgesia, it helps in reducing the airway edema and also helps in reducing nausea and vomiting in these children. In certain scenarios where it has been a wide palate, you are anticipating a lot of palatal edema, you may want to repeat 2 more doses of dexamethasone for the first 24 hours. The high flow nasal oxygen has been a big thing for the COVID times, and there are many centers who have high flow nasal oxygen available. This child, a little older child, he had a very bad scarred palate and underwent a little complicated palatal repair and ended up having palatal edema in the post-op period, because of which he was finding it difficult to breathe. And we tried putting high flow nasal oxygen for the first 24 hours, and it helped sail this child comfortably. But this is just one case that we have done, and I'm not very sure whether there is role of high flow nasal oxygen for all of these cases. Post-operative pain is an important component. Flack scale is used to assess pain in these children, and it is better that you stick to paracetamol or non-steroidal anti-inflammatory drugs in the post-operative period. There are many centers that use suppositories, both paracetamol or diclofenac suppositories, but we do not use suppositories because suppositories can have erratic absorption. So older children can be given ketorolac in the dose of 0.5 milligrams per kg. And in younger children, we prefer giving paracetamol syrup and ibuprofen syrup to cover the post-operative pain. Post-operative agitation is probably most difficult. The children will be irritable, they'll be thrashing, they'll bleed more, they'll cry more, and that will cause a lot of anxiety to everyone. So make sure that you've provided adequate analgesia so the post-op agitation is less. Having a mother console the child, I feel, is very, very useful in keeping the child calm. And beyond that, if anything is required, I have found Xylocard useful. I use it in the dose of 1 milligram per kg, diluted up to 5 ml, and that just helps put the child to a little bit of sleep without really obstructing the airway. Dexmedetomidine can also be used, but if you are giving it in the post-operative period, make sure you are monitoring for the next half an hour or so. The dose has to be given over 15 to 20 minutes. Another useful technique is using TIVA. TIVA has been associated with reduced post-operative agitation. There are just a couple of patients where we've tried using TIVA. So I have this video where we've connected the BIS monitor for this child. And as you can see that there is no inhalational anesthetic that is going on. And we are using the PCI pump to anesthetize this child with TIVA. So TIVA has specific indications, and that's where it can be used, but most of these children we give inhalational anesthesia. Post-operative feeding, try and feed while after the child are awake, usually 2 to 3 hours is when we start feeding our children. The first feed is an assisted feed. We give clear liquids, and milk can be started after 4 hours. If you think that child is not taking adequate orals, we write them up for IV fluids overnight. So when do you really want to send this child to what? The child should be alert, playful. You should be happy with the vitals. The pain control should look adequate. There should not be active bleeding. The child should have tolerated orals and should have passed urine. We do not send any routine post-operative investigations, but in case you think that the child has bled a little more, a post-operative hemoglobin can be sent. Now, coming just a last mention of the ERAS protocol. ERAS has been occupying a lot of surgical areas, and yes, even the plastic surgeons have been trying to use ERAS for cleft children, and these are the components of the ERAS protocol, the preoperative, intraoperative, and postoperative components, and I have discussed all of them in my lecture so far. So I think counseling of the parent is extremely important, making sure that the child is not fasting for longer duration, using short-acting drugs, multimodal analgesia, using dexamethasone, at least a single dose is useful, and post-operatively feeding them early is really helpful in helping them for early discharge. Thus, to summarize, managing these children is both science and art. Risk stratifying these children, identifying which children could be problematic is extremely important. Take help whenever you are managing difficult airway cases, because these children can sometimes not give you adequate time and they can just rapidly desaturate and crash. And also anticipating which children can develop post-operative respiratory obstruction, and taking adequate precautions is the key to success. For those who are interested, this chapter that I had authored in Textbook of Pediatric Anesthesia could be useful to have a little more read on this topic. Thank you so much for your patient listening. I thank my team, my hospital, and my patients who make me feel my job more meaningful as we spread smiles across the lives of these children. Thank you so much.
Thank you, ma'am. Ma'am, you mentioned about Xylopard in the post-op period.
Mm-hmm.
Can you please, we can use in other procedures in pediatric patients as a anxiety-related matters.
Yeah, so it can be used in other population also. In fact, it is quite useful in airway procedures, even in adults, is what I've found. Because I work in a cancer hospital, if somebody's had, say, tongue or a buccal mucosal lesion excision, and they are irritable in the early post-op period, Xylocard will actually suppress the airway reflexes sufficiently so that they don't become irritable, and also preserves the cough reflex. So it's a good balance between having a little calmer child or a little calmer patient without actually increasing the risk of aspiration.
Very nice. Now, one question from Dr. Veena Asthana, ma'am. She's asking any UHG-guided parameter to assess difficult airway.
So actually, such small children, I don't think there are enough parameters that have been assessed. There are a lot of parameters for difficult airway assessment that have been described for adults. If I use an ultrasound for airway for these children, the most important way to use it would be to identify the cricothyroid membrane in a child with a difficult airway, because that is something that is going to be extremely useful for you if you mark it and keep in the pre-op area. You can use it for rapid front of neck access. Whereas if you are trying to ask me in younger children, trying to measure different distances, I don't think it has been studied adequately. I'm not aware of it.
In your setup, you mentioned about video laryngoscope in children. What is your experience related to video laryngoscope? So which one should we use in private practice for our private forum point of view? I'm asking because we don't do regularly Cleft or palate surgeries, but a lot of pediatric surgeries are happening. So which one you think is best?
So there are many video laryngoscopes that are available with pediatric blades now. So whenever you are buying a video laryngoscope, just make sure you buy that extra smaller size blade. It will just cost you a little, but can be really very useful. There are a lot of Indian makes also that are available. So we have CMAC, and we also have the other one that is marketed by Anesthetics India, the one that I showed it in one of my presentations, that has got a lot of types of blades. It has got a pediatric McCoy blade, it has got a pediatric Miller's blade, and different size of pediatric Macintosh blade as well.
Dr. Naresh Paliwal sir is asking, what about combination of Dexkit in children's?
So a lot of combinations with ketamine and with dexmedetomidine and propofol have been used in various combinations. If you're planning TIVA, my use of ketamine is really very, very limited. I do not use ketamine for these children, particularly because I feel that it can actually increase the airway secretions and may add to the agitation. I'm not very sure. I don't use much of ketamine. The only place where I would really use ketamine is for a child where I've tried pre-medicating and the child has still not slept and just refuses to get engaged in a conversation and refuses to come inside the operation theater. Or somebody who is probably not is slightly mentally challenged, unable to really understand and communicate with you. So those are the situations where we've used intramuscular ketamine. But yes, these combinations have been used. There is literature on them, and I'm sure people who are using it would really be able to share their experience and tell us how it is.
Other question from Tejas Bhandari. Post-op fluid management, do you check sugar peri-op? What about delayed reversals, role of calcium pre-op if any?
Okay, so let's go one by one. I think sugar. So most of my younger children, anybody less than 5 years, would definitely receive 1% DRL. Actually, if you look at the guidelines, you do not require to give dextrose for this age group. You really need to give dextrose only when the child is much younger, probably lesser than 3 months or so. But in our institute, the practice is to use 1% dextrose ringer lactate for all children less than 5 years, and anybody older than that, we would just connect ringers lactate. In this age group, I mean, because the children receive glucon-D about 2 to 3 hours before surgery, and we start feeding in our post-operative recovery area, which is an assisted feed in front of the post-op nurse, and even an anesthesiologist is around many times. The incidence of hypoglycemia is not much. But if you are having a child where the mother has, because of some worry, has not really fed the child, please make sure that some amount of glucose goes, and 1% dextrose RL is a good alternative for that. The same can be continued in the post-op period. As I said, sometimes some children, even if we want to initiate orals, they do not take orals. They are unable to take orals. So these children, we continue 1% dextrose ringer lactate overnight, and we assess initiating feeding in them the next day morning. This percentage is relatively less, but we do have to do this in some patients.
Ma'am, you mentioned about, we'll take the next question, then we'll ask. Dr. Veena Asthana, ma'am, asking about UAG-guided suprazygomatic maxillary nerve block landmarks.
Yeah, so actually, suprazygomatic maxillary nerve block, ultrasound guided is definitely safer because it helps you identify the maxillary artery and be able to make sure that your needle and the drug that's being deposited is away from the maxillary artery. We've done ultrasound guided suprazygomatic maxillary nerve blocks in adult patients undergoing head and neck cancer surgeries, but even with the small footprint that I have found it a little challenging to identify the maxillary artery. But yes, if you can do it, that is the safest way of doing it, using ultrasound to identify the maxillary artery and then giving the maxillary nerve block. I completely agree with you, Veena ma'am.
So, another anonymous attendee is asking how to use xylocod as a local anesthetist or IV.
So I think the most important thing is use only Xylocard. Please do not use Xylocaine.
Yes.
Use Xylocard and use it in the dose of 1 milligram per kg. I usually like to dilute it up to 5 ml and then give it. And within a minute or so, the child would become calmer and may start falling off to sleep, or at least would definitely become calmer.
With this, any monitoring needed, ma'am, in children?
No, it doesn't cause respiratory depression. And I think that is something that I really like about it. Dexmedetomidine is also good, as I said, 0.5 micrograms per kg, but it needs to be given over 15 to 20 minutes. So we would add it on a, it's a little challenging to give it in a child who's really crying a lot, because the best way of giving it over 15 to 20 minutes is adding it in a burette set. But somebody has to keep holding that hand and the burette to make sure that it is going. If you give dexmedetomidine very rapidly, you should be monitoring the heart rate, because that can sometimes reduce the heart rate. Respiration, it does not really affect much, but yeah, Xylocard is much, much safer than dexmedetomidine in terms of respiratory rate depression also.
Dr. Tejas is asking, is intranasal preparation of Dexmed available, or IV Dexmed used in syringe and given intranasal?
That one ampule of dexmedetomidine that is available has been used through all the routes by so many people. And yes, there is no intranasal dexmedetomidine that's available. We dilute it up. And the advantage is that you can make it a little concentrated just to try and use how much you want to use it for children, so that the number of drops are reduced. And I think that is one advantage that I feel in children who've not slept with routine sedation, that you just trickle a couple of drops. You calculate 3 mics per kg. Probably if you look into the literature, they would say 2 mics per kg, but we have done a study where we've used 3 mics per kg, and within 15 to 20 minutes, the child will become calm, comfortable, will not really go as deep a sleep as triclophos, that is the chloral hydrate solution that we use, but it is very good for separation and steel inhalational induction.
Another question from probe size for pediatrics, in related to UAG from Dr. Veena ma'am.
Okay, so there is a hockey stick probe that is available that I actually showed in one of my videos that we use for pediatric peripheral lines, pediatric central lines. So a pediatric hockey stick probe is very useful. And I remembered that she had asked me the landmarks. So you feel for the zygomatic arch, and just above the zygomatic arch, you'll keep the probe tilting towards trying to to look behind the zygomatic arch, and then you would usually see a trough-like depression and a maxillary artery which is pulsating. You can throw in some color there, and you can see the maxillary artery pulsating.
Again, Dr. Veena ma'am, have you ever used melatonin for pre-medication?
No, I haven't used it, and never in children. One of my colleague had used it, the melatonin tablets as pre-medication, and tried to look at post-op awakening and the irritability, but I haven't used it ever in children.
Ma'am, Dr. Tejas is asking delayed reversal, the role of
Yeah,
calcium
I'm
in
so
drop.
sorry. I missed his
Yes, yes,
other two questions.
yes.
So I think delayed reversal can occur if you've been uh, overzealous in giving muscle relaxant, or sometimes the surgeon just makes you jittery. It's like, oh, the child has started swallowing, or they want to kind of they give some open up the gag a little more, which is much more painful stimulus, and you think the child has moved and you would want to give. So it is safer to use atracurium. I'm sure many of you are using atracurium for such small kids. And make sure you wait it out. For at least half an hour, 40 minutes before you attempt reversing. So continue your inhalational agent so that the child doesn't come out and there is no incomplete reversal. To identify if there is incomplete neuromuscular blockade, using a neuromuscular monitoring is extremely useful. We have neuromuscular monitoring devices with us, and if there is any doubt, you have to look at the TOF ratio. See, earlier teaching was we looked at the TOF counts, but recent literature says that TOF counts are inadequate. You need to look at the TOF ratios, and a TOF ratio of, recently they say 0.9 is what is required to make sure that the patient is able to maintain the airway. So 0.8 and above of TOF ratio will help you identify whether this patient is ready for extubation or not. Till the patient is not ready for extubation, we think that inhalational agent is, if we cut off the inhalational agent, the patient is going to wake up and start breathing in incomplete reversals. But if it is because of neuromuscular blockade, make sure that the neuromuscular blockade has received adequate time for wearing off and reversal before you awaken the child, because otherwise you will end up with inadequate reversal, which is very difficult to manage post-operatively in these patients. And the second thing he asked was the calcium.
Yes.
I don't use calcium for this age group because, as I mentioned, that we operate children only above 3 months of age group, and calcium typically is useful in neonatal population. In children who are lesser than 1 month, or those who've been preterm. And beyond that, I don't really think that calcium is useful for airway purposes.
Ma'am, you mentioned about Smile Train, and you work in train OTs. How's your experience in Baswatarkam OTs and train OTs?
There is a lot of difference, and that's where the challenges lie. And that's why I really am impressed by people who work in low resource settings and are still able to manage these patients safely and provide safe perioperative care. I'm really impressed by people who do that. So different ways that I know that my friends share is that sometimes just lip procedures, they would just do it under IV ketamine, where the surgeon is careful enough not to let the bleeding get soaked. I know some people do not would not even secure the airway, which I am very, very scared of. I would definitely put in a supraglottic airway if I want the surgeon to do anything around the lip. I think that is one take-home message that I want to give across, that never leave the airway unattended to. At least a supraglottic airway should be used in these type of cases. And then I know that people do manage these cases without inhalational agents, just with IV supplementation of propofol and ketamine combination. Ketamine, they would give initially in the dose of 1 milligram per kg, and top-ups of 0.25 or 0.5 milligram per kg as and when required, and propofol also in intermittent top-ups. And the reason that they give me is that my surgeon is extremely fast. They will usually finish these cases in half an hour, 1 hour. If you are really lucky to be working with such a surgeon, I'm sure you have devised your own comfortable way of managing these, but please make sure that the airway is secure. Do not do it with an insecure airway.
Thank you, ma'am. From Dr. Veena, excellent presentation. Dr. Veena. You always rock. She mentioned
Thank you.
about that.
Thank you.
So I will conclude this session, ma'am. It's a really thankful gesture from our ISSCT rank Nanded, all members. Glad that you came on our platform this evening. So I'm really thankful to you, ma'am.
Thank you.
Thank you.
Thank you so much for inviting me, and
Yes,
good night, everybody. Have a nice weekend. Bye bye.
thank you. Same to you.